Hi guys, my name is Sanjay Gupta. I'm a cardiologist in York, and one of my friends, Julie, contacted me a few days ago and said, could you do a video on the subject of pacemakers, particularly for those people who suffer from atrial fibrillation or AFib. Julie is due for a pacemaker soon. She's obviously a little bit concerned, so I thought I'd do a quick video on a little bit about AFib and what the benefit of having a pacemaker is, how it's done, and what the consequences can be. Okay, so the first thing to say is it's important to understand what atrial fibrillation is. Atrial fibrillation is when the atria stop working. So these are the top two chambers of the heart. They're called the atria here. Okay, this chamber here is called the ventricle. But there's a chamber here called the atria, and this is another atria. Now, what happens is when the heart relaxes, most of the blood will just flow into the heart by a suction effect into the ventricle. So the ventricle contracts when it relaxes, it sucks blood through, and the atrium is mainly a conduit. Okay. However, as the heart is beginning to fill up, towards the end, the atria will contract and push some more blood into the ventricle. And that amounts to about 15% of the total volume of blood in the ventricle. There is something called the Starling's law, which tells us that the ventricle is a little bit like a rubber band. It's a bag of rubber bands. So, you know, when you take a rubber band, for example, and you stretch it, it comes back together strongly. But if you stretch it even more, it comes back with even more force. So when the ventricle is filling up, it's stretching, but then when the atrium contracts towards the end, it stretches it by another 15% or so. And therefore, this results in a more effective heartbeat or a more effective contraction of the ventricle, i.e. more blood goes around the body. All right. The problem is that in atrial fibrillation, two things happen. The first is because the atria stop working, the heart pumps out 15% less blood than it would ordinarily. Okay, so that is the kind of hemodynamic consequence of developing atrial fibrillation. The other thing to say is that the sinoatrial node, or the natural pacemaker that God gives us, sits in here, right near the atria. So usually if the atria stop working, then we do get this sense that the pacemaker itself will also be affected in some way, the pacemaker that God gives us, all right, the sinoatrial node. So I normally tell my patients that atrial fibrillation is a disorder of rhythm because the heart beats irregularly as opposed to regularly, and rate. Because what tends to happen is when you develop atrial fibrillation, the inherent pacemaker that you're born with doesn't really quite do its job. And the pacemaker that we're born with has two roles. It stops the heart going too fast, and it stops the heart going too slow. So in patients who have atrial fibrillation, the heart can go very fast and sometimes can go very slow. All right. So it's a disorder of both rhythm and rate. Okay, so then you have to say to yourself, well, what does this condition do to me? Can this condition do? Any condition can only do two things. Okay, it can shorten your lifespan, or it can make you feel unwell. All right. In terms of atrial fibrillation, the main risk associated with this condition is the risk of strokes. The idea is if the atria are not contracting, then the ventricle is pumping out 15% less blood, and therefore 15% of the blood probably just isn't moving as well, and that can stagnate and form a blood clot. And that is why people who have atrial fibrillation, particularly if they're older or have diabetes or high blood pressure, are often recommended to go on blood thinning medication. But that really covers the risk associated with it. Everything else is about what it does to your quality of life. And for the majority of people, the quality of life is affected by two symptoms, or possibly three. One, palpitation, because the heart can race. Two, breathlessness, and the breathlessness is caused by two things. One, the loss of 15%, but that generally is not a huge cause of the breathlessness, but more so because the heart races. Okay, so sometimes in atrial fibrillation, when you're sitting, your heart can be racing at 120 beats per minute, and that will undoubtedly make you feel like you're doing an activity making your heart go at 120 beats per minute. So, and imagine if you then start walking, your heart rate may shoot up to 180 beats per minute, and that will make you feel quite breathless on modest levels of exertion. And the third thing is that it can make you feel tired. And again, that is because there's less blood going around the body. And because there's less blood going around the body and the heart is working so much harder, or is beating so much faster, you will get more tired. So in terms of quality of life, three things happen. You can get palpitations, you will get breathless on physical exertion, and you may just generally feel tired and lethargic, all right? And therefore, you are then left with the dilemma as to, are these symptoms predominantly because of the irregularity, i.e. the rhythm, or are they because of the rate? Because as I said, the rhythm, just by being irregular, you've lost 15% of your pumping ability, and the rate, because the heart can race. In an ideal world, what you'd like to do is get the patient out of atrial fibrillation. So you just deliver a small shock to the heart under general anesthetic, and sometimes you are successful. The problem is, for a lot of people, the atrial fibrillation has developed as a consequence of long-term changes to the atria. So the atria have become very big, they've become very flabby, and even if you shock the atria, you don't necessarily get the heart back into a regular rhythm, all right? And so, of course, there is the option of sending the patient for an ablation, which is another way of trying to get them into a regular rhythm, but otherwise you tend to be restricted. So sometimes you just cannot get the patient into a regular rhythm. At that point, then you have to try and concentrate your efforts on controlling the rate, okay? If the heart is going very fast when you walk, then by slowing the heart down, you can make the patient feel a lot better. They may not feel as breathless, they may not get as tired, and they may not have those palpitations, and thereby you improve their quality of life. Okay. Now, there's two things. Okay. The first thing is that if to control the rate, you have to often give patients medications. Okay. And you will get you'll get three sets of people. Okay, the first you give medications to, the rate comes down nicely, great, no problems, the patient feels better, you accept that they're going to remain in atrial fibrillation, you cover their risk by giving them blood thinning medications, and you control their heart rate with beta blockers, diltiazem, digoxin, and if the patient feels fine, nothing else needs to be done, because you've controlled their risk, you're doing something to control their risk, i.e. giving them blood thinning medication, and then you're controlling their or improving their quality of life by controlling their rate, and you're accepting that they'll remain irregular. However, there's another group of patients in whom you give all these medications to stop them going too fast, but remember, the pacemaker is probably not going to be working as well, and these people, then you start finding that they go too slow. Okay, so they'll go too fast at times and too slow at times, and therefore it becomes very difficult, because you think, well, how do I stop them from going too fast without risking them going too slow? Okay, those patients are said to have something called tacky-brady syndrome. Okay, i.e. fast, slow. Tachy is fast, brady is slow. Tacky-brady syndrome. So there is a subgroup of people with atrial fibrillation who develop this condition. And the problem obviously is that when their heart goes too slowly, they may feel like they're going to faint, and they may even black out. When they're going very fast, they get very breathless and they're not able to do things. And therefore you are now left in a dilemma. How do I control this? How do I get this patient better? So one option in those people is to put in a pacemaker. The pacemaker the pacemaker that man has made generally just stops you from going too slow, all right? The pacemaker that God gives us stops you from going too slow and stops you from going too fast. So in those people who have tacky-brady syndrome, what you can do is put in a pacemaker, and the pacemaker will then sit there and detect if the heart is going to go too slow and stop it going too slow. And so you then don't have to worry about the heart going too slowly, and you can give the patient lots of medications to stop them going too fast, okay? In those people, you put in something called a VVI pacemaker, which means it's a single lead, and all that the pacemaker does is it works on demand, okay? It isn't going to be firing all the time. It just sits there, waits. If the heart starts slowing down excessively, it fires and stops the heart going too slowly. Then there is another group of patients, okay? In those patients, no matter what you give them to slow them down, you simply can't get them to slow down, okay? And that then again is a problem because one, because they're not slowing down, they're taking they're going to be limited in terms of what they can do. Two, if the heart is constantly beating very fast for several years, then it will start weakening. So it's not a good idea to leave the person going fast for very long, all right? By that, I mean, leave them going very fast for years, all right? And therefore, people then say, well, what can we do if we simply can't get them to slow down despite all the tablets we have in our armamentarium? In those people, what you can do is something called a AV node ablation and then put in a pacemaker. Let me explain what that means. The atria are over here, okay? And these impulses are transmitted to the ventricles. And they're transmitted through a little structure here called the atrioventricular node, okay? So now, if you can break the connection between the atrium and the ventricles by zapping this node, then you can control the ventricles artificially using a pacemaker and leave the atria to fibrillate away. The atria are still going to fibrillate, they're still going to be irregular, but the ventricle is no longer listening to the atria, all right? And therefore, but the problem there is that if you break that connection, then the ventricles have nothing to listen to. So they need a pacemaker to keep them going. Now, often what happens is if you destroy the AV node, there will be some cells here which will start firing and the patient will still have a heartbeat, but the heartbeat will be very slow, around about 30 beats per minute. And that's way too slow to keep the patient functioning effectively. And that is why most people would then put in a pacemaker, okay? And the pacemaker would fire continuously at say 60 beats per minute, and therefore the ventricle will fire regularly at 60 beats per minute, but the patient is in atrial fibrillation, i.e. the atria are still not working and fibrillating. So remember, in an AV node ablation, you are not curing the atrial fibrillation, you're not taking the atrial fibrillation away, you're letting the atria fibrillate, but you're stopping the ventricles from listening to the atria. And therefore you are controlling the ventricles with a pacemaker, all right? Now, most people then say, well, if I've got my AV node ablated, isn't that dangerous? Because then I'm purely dependent on the pacemaker. And of course, yes, it is true that a lot of people can become dependent on the pacemaker, i.e. the pacemaker is the only thing that is controlling their heart rate or producing a heart rate. And in a group of patients, if that pacemaker stops altogether, then they don't have a heartbeat. However, there was a study done and they found that in about 55% of patients after an AV node ablation, there is still some activity that occurs. And that's why it's very important that when the person is ablating the AV node, he just ablates the AV node and he tries to preserve the tissue around here, because most of the escape complexes come from just below the AV node. And therefore, the closer you are to the AV node, the more likely you are to have a a better escape beat, a better quality escape beat. So although it is true that some people become pacemaker dependent, about half such patients actually do have an intrinsic rhythm. But despite this, the intrinsic rhythm is generally quite slow and would not be enough to keep them going or functioning normally. But it does mean that they don't, that their heart will just will not stop completely if that pacemaker malfunctions in any way. The good news about AV node ablation is it's very effective, because you're now breaking the connection and your pacemaker rate is controlled artificially. So you're not, it's highly effective. The other advantage is that we know that people who have AV node ablation do as well in the long run as people who are on medications. In fact, they probably do better than people who are on medications. Once you've had the AV node ablation, you don't need the medications. Of course, you still need blood thinning medication because the atria are still fibrillating, but you don't need any medications to slow you down, okay? Or slow the heart down, because the pacemaker controls what rate it is. I can decree the pacemaker to beat at 55 beats per minute, and that will become the heart rate. I can make the pacemaker fire at 70 beats per minute, and that will become the patient's heart rate. So on the whole, and so a lot of patients don't require lots of horrible drugs to slow them down over a long period of time. One thing it is important to bear in mind is that some people have something called paroxysmal atrial fibrillation, or that they have episodes of atrial fibrillation interspersed with sinus rhythm. There is a much higher chance of going into continuous atrial fibrillation with an AV node ablation, probably because you're not taking tablets anymore, compared to if you're on tablets. But that doesn't really matter, because for the majority of people, the problem is the rate rather than the rhythm, okay? So that's all I needed to say. I mean, a lot of people worry and they say, well, what happens if my pacemaker, my battery starts dying down? How would it happen? Because at the end of the day, I'm dependent on this pacemaker. The answer is this, that your pacemaker is tested every so often, and someone will know whether the battery is nearing the end of life. They will also know whether you're dependent on the pacemaker or not. If you are, what tends to happen is before the pacemaker is changed, someone would put in a temporary wire which will act as a pacemaker whilst the pacemaker box is changed. All right, so you don't have to worry about something like, the pacemaker just suddenly not functioning and the person dropping down dead. That very, very, very rarely happens. And on the whole, if you have a problem with fast heart rates which are not being controlled with medication, an AV node ablation and a pacemaker insertion is a very effective treatment. A lot of people ask me what kind of pacemaker. It's usually a good idea to have a dual chamber pacemaker, okay? You have a lead up here, and you have a lead up there, the lead down there. So the lead up here will communicate with the lead down there. It will fire, and after a certain time, this lead will fire, and the normal activation of the heart is maintained. Imagine if you just had a pacemaker lead here, then only this part will start getting activated, and the activation is the wrong way around. Remember, normally the activation starts here in the sinoatrial node, which is where the pacemaker is. It goes down the atrioventricular node, and then it causes the heart to fire. If you have a single lead pacemaker, you're activating here first and then going the other way around, which is not the way it should be. So it's always good to try and preserve this normal pathway by having a lead up here and here. Now, this lead can be ineffective if the atria aren't working. So in those people who are in chronic atrial fibrillation, often what the doctors do is they put in something called mode switching, which is that they will detect if the atria are not working at all, in which case only this lead will work. If, on the other hand, there is some atrial activity, then this will fire, and then this will fire, and this is a more physiological way of activation. So generally, I would recommend 2 leads rather than 1, unless you are in persistent chronic atrial fibrillation, in which case a single lead in the ventricle would be okay as well. What else did I want to tell you? I wanted to show you a pacemaker. just so that you know. And I'm going to just show you how it's put in. Here we go. I brought this specifically. Here we go. This is a pacemaker here. Okay. This is a pacemaker here. This is a typical dual chamber pacemaker. You can see two little holes here, which are for the leads. Can you see there? Two little holes. So what happens is, how do you put in a pacemaker? Let me show it to you. Here we go. I just wanted to show you these. Here we go. So what happens is, when you have a pacemaker, it's a very straightforward procedure. It's done under local anesthetic. Usually this area is used here. Okay, so you go into a lab where you're covered with drapes, which are sterile. The pacemaker insertion has to be done in a very sterile environment. And then what happens is the surgeon will give you some anesthetic here, make this area numb, and make a cut around about this big. Okay, there. Now, this should not hurt because you've got the local anesthetic, so you will feel a little bit of pushing and pulling, but generally it's not painful. Then the surgeon makes a little pocket with their fingers under the skin, all right? And this is the pacemaker, this is the battery here. So what happens is, this sits in this pocket, all right? But before they put this in the pocket, what the surgeon will do is here, just under the collarbone, you have your subclavian vein, all right? This is your heart here. Okay, so what they will do is they will, and this is where the subclavian vein is here. So what the surgeon does is he takes a needle and he goes under the collarbone and he punctures this vein, this blue vein here, all right? And then what happens is, through the needle, he passes this wire, and the wire will go down the subclavian vein here, like this, and it will follow down there, there, and then eventually it will reach. Eventually, it will sort of reach the ventricle. So you keep pushing it down, 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 goes into the ventricle, and then the surgeon will push it through the tricuspid valve here, okay? And it goes through the valve, and it just gets embedded in there. And now you've got a lead in the ventricle, and he does the same thing with another lead, and that goes again down this way, eventually in here, and it gets embedded into the atria. Once that's done, all that's left is that the other end of the pacing wire is put in, yeah, this is the tip of the pacing wire. You can see it's got these little things, and this is to catch, this is to embed the wire into the ventricle, which is a very muscular structure, so it'll just get caught into the muscle. And after a few years, you know, there'll be there'll be muscle that'll develop around it, and will make it very firm. Eventually, what happens is, once that's done, what the surgeon does is he takes the other side, he puts it in here like this. It's just going to show you like that, okay? And it stays there, and he puts the other wire in here, and then he pushes this into the pocket and stitches up. And it takes about 20 or 25 minutes to do. And that's what a pacemaker, that's how pacemakers put it, all right? After that, you usually just go home the same day. And to all intents and purposes, a pacemaker should not it should not stop you from doing anything you enjoy, all right? Of course, it's important to know whether your pacemaker is MRI compatible, because a lot of MRI scanners, you know, they don't scan patients who have pacemakers. So if you ever need MRI scans on a routine basis, you should request your surgeon to do an MRI or put in an MRI compatible pacemaker. But after a few days, you'll be able to work and live normally. You will not feel your pacemaker kick in. Usually you shouldn't. Apart from that, there is no reason you can't do anything you want to. You'll be able to do all the things you enjoy doing. The good news is you'll be able to enjoy your life a lot more because your heart won't be beating so fast and making you feel, you know, yucky all the time. So I hope this was helpful. Please just bear in mind that the pacemaker does not cure your atrial fibrillation. You're still in atrial fibrillation. You will still need anticoagulants if you're in persistent atrial fibrillation and your stroke risk is deemed high enough. But other than that, it allows you to have a good quality of life. And the good news is long-term follow-up indicates that people who have AV node ablation and pacemakers do just as well as those people who are on tablets. But at least they're not then suffering the potential side effects of lots of tablets. So I hope this was helpful. Julie, I wish you all the best. If you have any questions, if you have any concerns, if you're worried in the middle of the night, drop me a line and we can chat over the phone. But I'm sure you'll be great. And now I just wanted to plug my website. This is yourcardiology.co.uk. And this is my Facebook page, yourcardiology@gmail.com. And this is me. So I really appreciate all the great comments. I appreciate the lovely, lovely words and lovely comments that people leave for me. Please keep asking me questions. I will try and answer them eventually. And I wish you all the best. And if you found this to be useful, please consider sharing it and subscribing to the channel. Thank you so much. All right, bye.